biopsies, and I have for the last 44 years, because I was trained in Pittsburgh as a pathologist assistant, and that's where I first met Dr. Anderson. So I have no disclosures, and you can see I take pictures of hearts wherever I see them. This one has a VSD. So when I look at embryos all the way up through the fetal and pediatric period, you kind of have to know what's normal and what's abnormal for each stage. And so when we look at an embryo at this stage, which is between stage 15 and 16, Carnegie stage-wise, 35 to 38 days, you can see the embryo is kind of curly. The head is folded completely over the heart and some of the liver. The atrial components, you can appreciate, are quite large early in development. And the heart is actually developing in the neck region adjacent to the pharyngeal arches, which you can see there. And you heard earlier Professor Anderson talking about how the heart is actually attached to the pharyngeal mesenchyme throughout the cardiac development. So this is the same embryo. You can see on the left how it is curled. The head is curled over the developing heart. You can see that the atrium is still prominent, and we can recognize the ventricle, and the liver is actually quite large in the embryo and fetus, and it pushes up on the heart kind of against the head, folding over the heart. And so in the right-hand image, I've laid the embryo on its back and pushed the head away. So you can see the prominent atrial chambers and the right and left ventricles. Here you can see the subpulmonary outflow tract beginning to form so that the aorta is not yet in the left ventricle. And when we look at this same embryo a bit closer, at this stage, as I said, the head is still folded over the thorax, and you can see that elongated subpulmonary outflow tract. This is when the outflow tract ridges or cushions are approaching one another and the interventricular septum. And to put the aorta back into the left, or to put the aorta definitively into the left ventricle. And so it's not at this stage entirely committed to the left ventricle, as we heard earlier today. So the proximal outflow tracts are septated at Carnegie stage 17 between 42 and 44 days. So this is a similar slide to what Professor Anderson showed you earlier. And this is just kind of talking about what I just showed in the gross slide of the embryo. You can see the aorta still maintains its attachment with the right ventricle, and you can see the proximal outflow cushions beginning to form the subpulmonary infundibulum and wall off the aorta as they muscularize. You can see that secondary interventricular communication as well. So this is, again, a similar slide that Professor Anderson showed you, and I'm sorry, I should have put on here with permission. That's my fault. I usually make sure I do that. So thank you for the use of these slides, Professor Anderson. So you can see that the aortic root is still sitting atop the right ventricle, and you can see where the septal cushions are now fusing, and that is the area where they will fuse, and here is now the secondary interventricular communication. So you can see that the aorta is becoming committed to the left ventricle, and that secondary interventricular communication now forms the left ventricular outflow tract. So if we look at this, again, four-chamber view, as the aorta is progressing towards the left ventricle, you can see where those cushions are nearly fused and where the tubercles from the atrioventricular cushions will actually fuse to form the membranous septum and completely wall the aorta off into the left ventricle. So here you can see where the aorta is kind of still floating over a component of the septum, and you can see that the inner heart curvature is still muscular and has not yet resorbed between the aorta and mitral valve to form that fibrous continuity. And if you take a similar four-chamber, or actually echocardiographically, you guys might call this a five-chamber view of a normal heart, you can see the aortic valve and mitral valve are now in fibrous continuity, and the aorta is still kind of riding the interventricular septum, even though it's closed and it is now committed entirely to the left ventricle. So it still rides the interventricular septum to some degree. And this is nearly at the end of the fetal period or embryonic period. So you can see the fingers are nearly separated. There's still a little bit of a ray in between them proximally. The rays of the toes are still there, so they have not yet separated. But I just am showing this to show you, excuse me, how the head is totally covering the heart at this point, and the liver is pushing up. So you have those two opposing forces that as the head straightens out and you get to the fetal period, that still are acting on what we see in the actual early fetal heart. There we go. So this is a fetus at 11 weeks gestation. And you can see that the atriums are still quite large, but you can start to appreciate their morphologic characteristics as things begin to remodel. So there you can see that blunt or triangular tip to the appendage, and you can now appreciate that there's probably a broad junction with the venous component. You can now see a little finger-like tip to the left atrium, even though it is still quite dilated. And I know in the embryonic and early fetal period, there's a lot of blood flow going through the atriums. You can now see the coronary arteries on the epicardial surface. So that's the very distal component of the anterior interventricular coronary. And now you can see that the arterial trunks are easily appreciated, and they look normally related as they're exiting this particular heart. And this specimen was from a fetus that had trisomy 13. And I don't have the face here, but there was actually cyclopia in this particular fetus. So there was a VSD and some valvar dysplasia. The atrioventricular valves, I will mention, are not fully developed until closer to 13 weeks or during 13 weeks. And I'll show you towards the end of this what they look like. And when I'm training people to look at these fetal cases, I have to point these things out because at 13 or 13 and a half weeks, they may call tricuspid valve dysplasia or mitral valve dysplasia when it really isn't. It's just a progression of that normal development. So when we look at these hearts in early gestation, this is at 12 weeks. You can see the position of the apex of the heart is well away from the left ventricular chest wall. And the heart shape is actually a bit different than the term shape or the adult shape. It's much more globular and round looking. So the contours are a bit different. You can see that the atrial appendages are typically very large, but as we discussed, you can identify them specifically by their pectinate muscles and by their attachments with the venous component. You can see the position of the anterior interventricular coronary is much more towards the midline, whereas in the term heart, we see very little of the left ventricle. The base of the heart is actually rotated a bit more posterior in the mediastinum, and you can imagine that happening because of the head pressure and the liver pressure. Everything is being pushed more towards the spine. So the size of the liver in these early fetuses looks very symmetric. The left and right lobe are hard to differentiate. And you can see that the top or the diaphragmatic surface is actually pretty flat, not so much rounded. So there are different sizes of certain organs in the fetus. The adrenals are often almost as big as the kidneys early on, and the ovaries can look quite large too. So this is a comparison between 12 weeks and 18 weeks, and you can already see the differences in how things have begun to remodel. So the midline I have marked with the yellow line, and you can, even though it looks very askew in this 18-weeker, you can still mark the midline by looking where the clavicles are, where I've resected that to remove the chest plate. So you can see how the heart has actually remodeled and moved more into the anterior mediastinum. You can see the position of the anterior interventricular coronary, and you can see a lot less of the left ventricle in the 18-weeker. The liver has actually remodeled where the left lobe becomes smaller and allows the heart to shift more into the left chest. And you can see how the diaphragmatic surface is much more rounded than it was in the early gestation. So it's important to know how these things remodel when you're doing autopsies or looking at these things, to know what the subtle differences are between normal and abnormal. So you can see the size of the heart is exponentially different between 12 and 18 weeks. And there I have the coronaries marked as well. So on these fetal cases, we can identify hypoplastic ventricles by looking at the coronaries. So this is a case at 15 weeks, and you can see the coronaries outlining a hypoplastic left ventricle. The apex was to the right in this specimen, and there was isomerism of the right atrial appendages as well. And this was in a 10-week fetus. It was quite macerated, but you can see that there was tricuspid atresia. There was a hypoplastic right ventricle with the coronary marking that hypoplastic right ventricle and the dilated right atrium. There is what the fetus looked like. It was probably, this big. And there was a right aortic arch with mirror image branching. So we can diagnose these complex congenital heart diseases in the very early fetus. So some of this is going to be repeat of what we saw earlier today, but there's nothing wrong with a little repetition to help us learn things. So when we look at the heart in the chest, we look at its position, and we also look at where the apex is. They are two different descriptive categories, because you can have these two descriptive features that don't go along with one another because of other opposing forces. So the heart can be entirely normal or with congenital malformations and have the apex to the left, but the heart be in the right chest, or the apex to the left and the heart, or the apex to the right and the heart be in the left chest. So they're two different descriptive features. And some of the stuff we have to assess in fetuses are hydrops, because that's a mechanical thing that can displace the heart in the chest. So you can see the extensive fluid that was in both pleural cavities. They have rounded edges on the lungs, and the heart is actually in the midline, with the apex in the midline. So there was also hypoplasia of the arch and hypoplasia of the left ventricle. So we learn a lot from what we look at on the outside of the heart. And here you can see there was also a persistent left superior caval vein, and that there was no brachiocephalic vein, which is often the case. So there's diaphragmatic hernia. So you can see the diaphragm was deficient. The liver and the lung were, the liver and some of the intestine were up in the chest, and the lung was hypoplastic. So you can see the apex is to the midline, but the heart is in the right chest. And also other mechanical things that can change the position of things are omphalocele or gastroschisis, where everything kind of gets pulled downward. So some of the morphologic concepts that we went over this morning is using the morphologic method along with sequential segmental analysis and looking at the heart in attitudinally appropriate fashion. So the cardiac structures need to be described relative to the bodily coordinates, and all structures in the body have 3 orthogonal planes, and the heart itself has its own orthogonal planes. So this is a fetal heart and lungs that I cut along with the aorta and esophagus, and then I put a piece of the spine there to illustrate the anatomic relationships. So you can see that the midline of the body the heart has about a 45-degree angle to the midline of the body. There are the pulmonary veins, which we talked about earlier, being the most posterior structure of the heart. There's the terminal crest, which you can see is quite prominent. And I have this same heart compared to a normal fetal or a normal newborn heart towards the end to see how some of these structures remodel as well. And there's the mitral valve and the tricuspid valve, and you can see the normal offset even at this stage. So we talked about the morphologic method and using the most consonant component to identify the chambers, and how we can't use one variable feature to describe another feature, which is itself variable. So for sequential segmental analysis, We look at the three segments, the atriums, the ventricles, and the arterial trunks. And this is all going to be a little bit of a repeat from earlier, but we can see the body, the appendage, the venous component, the vestibule, and the septum. And the most constant we know is the appendage. And we can distinguish the appendages by their shape, by their junctional morphology, but the pectinate muscles are the most constant component. And that will apply even if you have significant hyperplasia or hypoplasia of the atriums or significant hemodynamic dilation. So this is just a comparison of the atriums from the outside, a triangular tip to the right. That's the entire appendage, the anterior aspect, and you can see the broad junction with the venous component. The left is a finger-like or tubular appendage with scallops along the edge and a very narrow junction with the venous component. Looking inside of the right atrium, we know that the oval fossa is a variable structure, and the pectinate muscles are our constant morphologic characteristics surrounding the right atrioventricular junction. You can see the coronary sinus, and actually I'll point out the area of the right atrial body is right in this area between the inferior extent of the oval fossa and where the inferior caval vein joins the right atrium. And all these little fenestrations here are remnants of the left venous valve that typically resorbs during development. And you can see this cut edge with this cut edge here. That is the eustachian valve, or the valve of the inferior vena cava, which directs the blood fetally across the oval fossa and blocks the majority of it from going across the tricuspid valve. So there you can see the right atrial vestibule, which is that smooth component between the distal end of the pectinate muscles and the hinge line of the tricuspid valve. And looking at the left atrium, you can see the narrow junction where the appendage joins the venous component and the pectinate muscles confined to the appendage, and that entirely smooth vestibule. There is the horseshoe-like structure where the flap valve is a little bit deficient in this specimen. It's not yet overlapping the superior interatrial fold. So just a slide to say that the atrial appendages kind of remodel as we get through gestation, and you can see here that this newborn heart is looking very much like what we see in the adult heart. So the ventricles, again, they have an inlet, an outlet, and an apical trabecular component, and the apical trabecular component is the most constant. The atrioventricular valves will go with their ventricles. The tricuspid valve is a morphologically right structure, and the mitral valve a morphologically left structure. So here we can see the comparison between the two ventricles. Both ventricles have an inlet, and the inlet is marked from the hinge line of the atrioventricular valve to where the tendinous cords join either the septum or papillary muscles. There you can see the outlet supported within each of the ventricles, and the apical trabecular component is the most constant. Fine and crisscrossing on the left and coarse on the right. So the arterial trunks, there are two in the normal heart, and they're identified by their branching pattern. So there's a widely patent arterial duct, which we see in the fetal population. And there is the branching pattern of the aorta, is the first of which are the coronaries, and then the brachiocephalic arteries, and the pulmonary trunk bifurcates to the right and left pulmonary arteries. So the things we look at in the fetus, if we see nothing in the placenta, nothing in the maternal environment that causes the intrauterine fetal death, I make sure I ask all the time, if I'm training someone, did you check the arterial duct? Did you check the oval fossa or and the venous duct? And so when you see an atretic or a constricted arterial duct, the pulmonary trunk will typically be dilated, as will the right atrium and maybe even the right ventricle, because the fetal blood is not getting across that arterial duct. And you can see the one on the right is very thin, and then the one on the left is quite constricted as it joins the aortic isthmus. The oval fossa, we always check to make sure that it's not prematurely closed, and you can see this one is bulging quite a bit, so it was closed in utero. And I also check the umbilical artery. When I first cut the umbilical vein during my initial incision, and I looked to see if it's dilated. This case, it was really dilated. So I knew to search a little bit farther. And so here you can see that the umbilical vein is going right up to the right atrium, and it was dilated. There's the venous duct, but above the venous duct, there was a constriction, or if you want to call it a little coarctation, and the portal vein was actually really dilated in this case as well, as were the hepatic veins where you can see my probe. So I often have people ask me, how do you tell if an aortic arch is hypoplastic in the fetus? Here you can see the arch from the front with the arterial duct going over the left bronchus. And here I've pulled the lung out and you can see it in the chest. I often look at the size of the left subclavian and the aortic isthmus and compare them if I think something is hypoplastic. So here, this is at 11 and a half weeks, and you can see that the arch might seem hypoplastic to you, but remember that there's not a lot of flow going out the aortic arch, and that a lot of flow is going through the arterial duct. You can see how large it is in this 11 and a half week specimen. So the aortic arch is much larger than the left subclavian artery. So I wouldn't call this hypoplastic arch in this 11 and a half week fetus. And you can see when I've opened it that it doesn't appear stenotic, and you can see that large arterial duct opening marked at the red arrows. And this is just another case of ductal stenosis showing the dilated right atrium and pulmonary trunk. So this is that heart I showed you earlier, where all the muscular structures look quite bulbous or thick. You can see the superior interatrial fold and the pulmonary veins on the left side of it. You can see that's the flap valve at the floor of the oval fossa. There's the terminal crest, which looks very thick. And here you can see the muscular buttress, which also looks quite thick. There is the membranous septum and the atrioventricular component and the interventricular component. So in the newborn heart, you can see how these things from the early gestation have remodeled. And there's our superior interatrial fold, our flap valve at the floor of the oval fossa. There is the muscular buttress and the membranous septum with the atrioventricular and the interventricular component. So things do remodel as gestation progresses. And so when I'm teaching people how to look at these fetal hearts, all of this is important so that they know what's normal and what's abnormal and what can be subtly abnormal. So this is a comparison of the tricuspid valve at 13 weeks and at 17 weeks. And you can see here the anterior papillary muscle looks like it's directly attached to the edge of the tricuspid valve, and that's because the tendinous cords have not yet totally formed. The edge of the valve also looks quite dysplastic relative to the septal surface, and again, because the tendinous cords have not yet totally completed their development. And then you can see at 17 weeks, the tricuspid valve looks much more normal with the tendinous cords attached to the septum and the cords to the anterior papillary muscle. Here, the mitral valve looks not quite normally formed, and you can see the tendinous cords beginning to form here to the tips of the papillary muscles, but not yet separated. And this is at 16 weeks, where you can now see definite tendinous cords attached to the papillary muscles. But look at this. There was also failure of the inner heart curvature to resorb. So there's a subaortic infundibulum in this fetal heart. But I don't know if Professor Anderson can address this if he's still with us. I don't know if that would have resorbed later on in gestation or not. But it's something that I look for in all of these fetal cases that I do. So variations in anatomy can be highly predictive. So we look at everything in situ before we cut anything. Abnormal systemic and pulmonary venous connections can be easily missed. Coronary arteries give us good hints as to what we might be finding in the ventricles. We use the morphologic method. and describe all structures, whether normal and congenitally malformed. And sequential segmental analysis helps to identify any abnormal or absent connections. And this is my hand. So this is some of the hearts that I look at. So we definitely have to know what happens during development and how things progress from, subtle variations to normal. So when I'm teaching people how to look at these fetal hearts, I have to teach them what is normal and what's abnormal and how to look for other things in other systems compared to what you see in the heart. And as I was told when I was initially trained at All Children's, if you don't look, you won't find it. So we try to look for everything. So I hope I'm not too far over time. That was probably about 12 weeks. 12 or 13.
I'm still here, Diane.
Questions?
Hi, can you hear me?
Sure can, yep.
That was a fantastic presentation, and those pictures are quite amazing. And the subaortic infundibulum should have gone by 15 weeks. So we have some serial histologic sections that we're going through at the moment, and the aortic to mitral continuity is established certainly by 11 weeks. But you're right, Diane, it takes its time to develop, but in that 15-week, the subaortic infundibulum would be an abnormal finding.
We had some conversation earlier about so-called non-compaction or retention of fetal trabeculations. And as I just mentioned about the remodeling of the structures relative to the arterial valves, maybe you can explain a little better than I tried to about how things coalesce. People were asking how you end up with a Swiss cheese type of ventricular septal defect. And, I know from what you've told me that things coalesce to form the papillary muscles and the tendinous cords and the septomarginal trabeculation, and that there are immunohistochemical differences between the compact layer and the trabecular layer. So maybe you can tell us a little bit more.
You're entirely correct that the walls themselves do not compact, whereas the ventricular septum does. And as you say, the papillary muscles also coalesce. So what you have said is correct. And if the persistent trabeculation, what is called at the moment non-compaction, is actually persistent trabeculation, as you've said. So you're 100% correct.
How do we end up with the Swiss cheese type of VSDs? For sure.
I think that is because the septum has not coalesced properly, and we saw that. We have a colony of mice in which my colleague in London perturbed the furin enzyme, and some of those have retained the non-coalesced septum, which more or less produces the Swiss cheese septum. So I think the Swiss cheese septum is indeed lack of coalescence or compaction of the trabeculations.
Oh, I was pretty much on it when I tried to describe it earlier. So
absolutely, you're 100% correct.
Anybody else have any?
Yeah, for Diane, the in terms of the CDH images you were showing of fetuses with CDH, I know one of the theorized reasons why you have hypoplastic left-sided structures is perturbed flow across the foramen ovale, given the mediastinal shift. Is that that orientation between the eustachian valve and the PFO and CDH, something you've observed in your fetal autopsies as well?
Well, and I know Professor Anderson will stand by this, that hypoplastic right and hypoplastic left heart are entities that arise after the heart has normally formed because the septum is intact. So everything has moved to the right place and the septum is intact. So I have seen fetal cases that have had intact atrial septum. Obviously, not all of them do that we see in the population of hypoplastic left heart. And I'm not sure that anybody knows what causes it at this point for that perturbation of the normal or the normal continuation of development for those ventricles not to become hypoplastic, whether they have the different phenotypic features, you know, as we see with hypoplastic left heart with stenosis, atresia, and atresia. So I don't know if you have any comments. Nobody really knows what happens, I don't think. And there are no
Absolutely.
mouse models.
Correct.
So the anatomy of the atrial septum and the eustachian valve and all that stuff is variable. As we talked about, we're all different in this room, and so are the way things form relative to the different defects. I mean, there's lots of variation out there.
Thank you. Do we believe the presence of a persistent left SVC affects mitral valve growth? And what are all the mechanisms do we believe that contributes to it? Thank you.
Can I comment on that?
Yeah.
That's a very good question, and we're looking at that at the moment. I mean, it's suggested that persistence of the left superior cable vein contributes to division of the left atrium, and I think it can do, but it can't be the only cause, because we know that there are a lot of individuals who have persistent left superior cable veins who don't have divided left atriums. And on the other hand, there are lots of patients with divided left atriums who don't have persistent left superior cable veins. So it's a very interesting association. And Diane has sent me some pictures of divided left atrium recently, and I'm working on this with her and a guy from India who's a radiologist called Neeraj Pandey, who is quite spectacular. And this morning, he sent me a picture of a patient with a persistent left superior cable vein, and the persistent left superior cable vein had indeed produced a fold into the left atrium, but it wasn't a divided left atrium. So it's a very interesting association, but I don't think we yet know the answer to it. It certainly isn't an all or none phenomenon.
I have a picture that I need to send you then. Because it was a 15-year-old who did not make it through her chemotherapy for leukemia, and she had an incidental finding in an otherwise normal heart of a persistent left superior cable vein, absent brachiocephalic vein. So she could have totally lived normally with that. But as she became an adult, I'm wondering if she would have had any mitral valve issues, because her left cable vein was so large that it protruded quite a bit over the mitral valve inlet. So I don't know. I haven't seen many hearts with that large of a persistent left cable vein, but I guess they could cause inflow obstruction.
What you describe is exactly the same thing that Neeraj sent me this morning. So we have to put those cases together, because that's fascinating.
All right,
It could well have obstructed and his patient is still alive, and his patient is also 15 years old. So what a coincidence.
Well, and if my patient didn't have leukemia, I wouldn't have the heart. So, she
Right.
could still be alive as well.
Right. Well, we have to put the two together. I shall tell Neeraj.
Okay, I'll send it.
Perfect.
Sounds like
I've-
they're all happy.
Oh, I have one more question, Bob. A couple actually, but I'll fire this one off first. It's related to the field that you've both made an illustrious career out of, and that you've helped the community so much with. And it's sort of a two-pronged question. I'm curious, in light of dwindling libraries of hearts due to, lack of succession in some cases, more often due to regulatory barriers. How do you see the future of the field? And what role, before we mention cross-sectional imaging and other types of imaging that kind of fill the role, we're hearing a lot about digital twins, et cetera. Is that enough to fill that role, both from an education but also from a research perspective? And I guess loosely related to that, one thing I'm taking away from even these few sessions this morning is how important it is to understand the fetal development in order to be able to understand what the anatomy is postnatally. And, maybe you can also dip into answering, how we should go about furthering the field, from embryological development to the final product. So I guess a bit of a broad question, but pick from it what you will.
I think you make a very good point there, because I'm very impressed with those pictures that Diane's just shown you of those fetal hearts. I've never seen fetal hearts that have been photographed and demonstrated in such an exquisite fashion. We have a large number of serially sectioned fetal hearts, and I'm working with some of those at the moment. So I've got the histological sections, but I've never seen them as beautiful as Diane presented them today. Of course, many of hers are abnormal, but I'm presuming, Diane, you must also have normal fetal hearts?
Yeah, the majority of, probably over half of what we see are normal, but we treat them the same way every time. And tomorrow, if you are all at the pediatric grand rounds, I'm talking about the autopsy, the pediatric and fetal autopsy. And I have a number of pictures of what we find in dilation evacuation specimens, all the way from 11 weeks up to sometimes 20 weeks. Now they do them, or 22 weeks. It depends on the autopsy permit parameters in each state. But we find quite a bit of congenital heart disease. And even if we don't have the heart, we can lead back to the MFMs of what might have been. Seeing a really hypoplastic aorta compared to the pulmonary trunk with no heart pretty much was going to be a hypoplastic left heart, or it's leaning that way. I have had cases where we have no heart, but I could diagnose a common arterial trunk because I see the pulmonary arteries coming off of the same trunk as the aorta. So there are a number of things that we can go back to the MFMs and give them some information, even if it's not complete. And I think that it's a good a retrospective educational thing for echocardiographers. If we find something that you guys didn't see, you can go back and look for it, and then maybe next time you'll be alerted to it. Not every MFM is open to doing that or dedicated to doing that, but we try to give them as much information at Tampa General as possible. And even our fetal cardiologists at All Children's work with the MFMs at Tampa General. So there's still some communication autopsy-wise between our fetal cardiologist and what we do at Tampa General. So, and not everybody does fetal autopsies. Some people just do a gross examination. So are you leaving the family history with a gap because you're not looking? How do you tell a mother if she's had 3 miscarriages and the first 2 weren't looked at, but the third one has some really strange abnormalities? So I guess I'm biased because of what I find in these cases. So we aren't allowed to keep a lot of our fetal cases. And now, because of autopsy permits changing, and I'll speak to some of this tomorrow. Our autopsy permit now has multiple boxes. Internal organs. Well, first of all, restrictions: no head, only chest and abdomen, only chest. Then there's other boxes: return all organs. Return all organs not necessary for diagnosis. No need to return organs. So if we have a macerated fetus and we have no restrictions, we have to cut a brain that is flattens out as soon as we put it on a hard surface. So some of that is restrictive pathology wise, because we can't get a good assessment, because we aren't allowed to fix things. Brain normally fixes for 10 days to 2 weeks. So there are a lot of variabilities these days that have changed with the autopsy permit as to what we are restrained with in pathology. So from when I started in 1982 until now, autopsy pathology has changed quite a bit. But if we have a congenital heart and we have to return it, we have to return it, and we have to respect the family's wishes. So that is impactful with some of the collections these days.
But you can, Diane, photograph it before you return it.
Yeah, yes. And the
I mean,
only
to
heart.
me, that's the most beautiful thing you're doing, because your photographs are quite exceptional. And by taking the photographs at the different stages, that's giving us so much information. The stuff you showed us today was, to me, is amazing. I was not aware, and I've looked at these things in histologic sections, but I've never seen them in the beautiful photographs that you showed us. So there is so much information that you're uncovering. I think you need to keep on doing this and to document it and to make it available. I think it's spectacular.
Well, I have so many pictures.
And there's only so much time.
And I did do an autopsy at all children's where there was complete mirror imagery, and we had to return all organs after fixation. So I opened that heart following the flow of blood. I glued it back together, and I cut it in 4-chamber plane. And then when we were done, we sent it back. But I would love to have that heart to show you all, but like I said, we respect the family's wishes. So,
but you have the pictures.
Yeah, I do.
And the other point that Lars was making in asking the question, I think that you're also doing a wonderful job with curating the various archives, and we have to immortalize the archives, because that material we're never going to get access to again. And I mean, you have access to the Van Meerop archive, which is wonderful. You work in Chicago with the Idris archive, which is also spectacular. There's every chance you're going to be able to go back to Pittsburgh. There are some wonderful hearts in the Pittsburgh archive, and we need to immortalize all of these archives, because that's the answer to all of our problems. The material is there if we know what to do with it.
The trouble is I only have a limited amount of time left.
Indeed.
And
likewise.
I am trying so hard to find someone to train, but one big obstacle: nobody wants to pay a trainee, because they're not worth anything right now until I'm with them for 5 years to take over. And there aren't a lot of people who are financially able to just quit their pathologist assistant job and to do what I do and not get paid what they get paid to be on the surgical bench. And as well, all of you cardiologists have to get your units in, so you don't have the time to spend in the pathology lab or with an archive. So there's a lot of obstacles these days with just everything, every financial concern and everybody's time concern. And it's just very sad, because I had long conversation with Michael about parting with some of these collections that I've cared for like my own child.
Well, you still have time yet. We need to make the most of what time we have available to us.
Yeah, I agree, but it's just very sad that I can't find anybody to step in.
I understand exactly what you're saying. So,
Anybody interested?
well, you need a rest before you do the inlets. So, great presentation. So, thanks very much.
All right, I guess we'll see you tomorrow, Bob. I
You
guess
will indeed. Great
if
day
Lars-
today. Well done.
I think
See you all
Lars
tomorrow.
has one question.
You know, on that note, maybe the way to elevate the importance of this field is to embed it more deeply as a requirement in training of radiologists, cardiologists, etc. On that note, I really want to encourage our fellows here to ask lots of questions. There's no stupid question. That's the beauty of coming together. If you don't ask questions, I'm just going to assume next time we read an echo and MRI together that you know all of this. So, you know, I want to ask a stupid question. I think I've got a reasonable handle on the superior sinus venosus ASDs and just from imaging, I don't see it.
ASDs.
What's that?
Interatrial communication.
Interatrial communication.
Oh, yes. Oh, on that note, here's an anecdote. One of the first papers I ever wrote was a case report that I submitted to Cardiology in the Young. There's a Dr. Anderson was the editor in chief, and it was a case report. And back came an angry letter, not to me, but to my boss, Dr. Reddington, for allowing me to use such frivolous words as superior vena cava or main pulmonary artery instead of pulmonary trunk and superior caval vein. I should have kept that. It was read all over. And that really scarred me for life. And so I try not to do that, but I did it again. Superior sinus venosus atrial communication.
Interatrial communication.
Interatrial communication. My gosh, I can't get it. I have a reasonable handle other than the terminology. Do I just transfer it to the inferior kind and also assume if the inferior caval vein overrides and the pulmonary vein drains to the wrong atrium, that's a sinus venosus interatrial communication? Is it kind of akin, or is there differences?
No, that's exactly the same. That is when the right inferior pulmonary vein is anomalously connected to the inferior caval vein. And Diane has a lovely example of a middle sinus venosus interatrial communication where the middle right pulmonary vein just goes into the systemic venous sinus to neither of the caval veins, but produces the hole sort of midway between the superior and the inferior caval veins. So it all makes sense. They're all interatrial communications because of anomalous connection of the particular pulmonary vein that has retained its left atrial connection.
That heart's in the Idris collection in Chicago.
Yes.
All right. I think with that, we'll conclude this session and come back in about 30 minutes for our last session of the day, which is inlets. And to Professor Anderson, we bid you good night.
And I'll see you tomorrow. Great
See you
day.
tomorrow.
Well done.
Thanks, Bob.
Thank you. Bye.